Hello, 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 hello. Good morning, good noon-ish. Can't be noon. Good afternoon. Welcome to Thursday's edition of Virtual Morning Report. It is a time where I get to hang out with my dear friend Charmine, the CP Solvers dream team, many of whom you might recognize: Rafa, Gerline, Kirtan, Sukriti, Travis, Anne Marie, and many others are here. I am hanging out outdoors in San Francisco at a lovely dog park with many, many dogs. And that over there with my poopy camera is the bay in San Francisco next to the Pacific Ocean. It's a miracle this Thursday because it's actually very, very warm. And so I'm going to stay out here for the hour hanging out with you all. By you all, of course, everybody involved here, all 40 of you, but three very special people. We would love, as per usual, for somebody to present a case, and are also hoping for two people to jump in and discuss the case with us in the lukewarm seat. So I'll pass on the mic to Charmine and emphasize the case presenter and two people to discuss with us.
Hi, all. So good to be back for another Thursday VMR edition. Can't wait to have a case presenter and two people to discuss. Yesterday's case was really interesting. And I'm sorry to go to the punchline because the patient had underlying HCV and he had a dorsal hand ulcerous rash. And we all, like, including me, thought it was like cryo because it tends to be like a more common skin manifestation, but it turned out to be sweet syndrome. What? It was my reaction. So it had been a while since I've thought of sweet syndrome. So actually, sweet syndrome is kind of like the triad of acute onset of fever, leukocytosis with like neutrophilic predominance tends to be, and like this tender erythematous plaque that is infiltrated by really mature neutrophils. And it's actually tends to be in terms of the distribution of this plaques tends to be in the face, upper trunk, extremities as well, mostly in women. And the hallmark of it is actually this great response to steroids. So it's like one of those rashes that we want to be able to recognize because we can treat it. And there's like links to drugs, IBD, and cancer, but there's a variant of it that I think this patient had, which is a neutrophilic dermatosis of dorsal hand. It's called a variant of SUIT because it's like a singular localized rash, tends to be on the dorsum of the hand. Um, so and hence the called the variant of it. And what is interesting about it in the pathology that it's not only like neutrophilic infiltration, but you have this like leukoclastic vasculitis. So there's this debate going on whether is it a true vasculitis, is it not? So is it a variant of Sweet syndrome? But the thought actually is that it's not a true vasculitis because the changes in vessels that is observed tends to be most likely infiltrate and the intensity of neutrophils that damages the vessel. So it's thought to be a secondary effect. And just like this variant of SUITs, just like anything else, is that you want to rule out infection first. And there's other diagnoses to consider, most notoriously pyoderma gangreosum, pustular drug reactions. And in terms of like observed associations, which HCV is one of them, is actually this rash is quite rare to begin with, but you can see it with like, lymphoma, leukemia, myelodysplastic syndrome. You can see it actually as a drug reaction and response to lenalidomide and thalidomide as well, which I don't know about. And also our friendly autoimmune diseases like IBD, seropositive arthritis, and sarcoid. I saw like a case reported with actually a flu vaccination. I don't know if that's correlation or causation. And again, like the treatment, it responds really well to steroids and dapsone. So thank you, Rafa, for presenting that case. And it was a great discussion with the teams. So, and it gave me a chance to review my SUIT syndrome. So thanks, Rafa. It was very sweet. No pun intended. It's funny.
Oh, come on. That pun was totally intended. How was it not
Maybe
intended?
intended.
That was a beautiful recap of yesterday's case. And actually, I didn't have this. Oh, I'm sorry for the noise. Um, I didn't have this at all on my radar, and learned a lot about it prompted from yesterday's case. So I will tell you, there's there's really something very special about sitting back and actively participating in the discussion. I wasn't at all contributing yesterday in real time, but still to this very day, try to really like systematically to think through the case, even when we're in the background. Um, so I am looking now in the chat to see if there's anybody who has volunteered, and I don't see anybody yet. And ooh, Kirtan, okay, all right. Jump on in and say hello, please. And I'll encourage one more case discussant and most crucial of all, a case presenter, please. Kirtan, please say hi.
Hello everyone, myself Kirtan Patolia. I'm a final year medical student from India, and it's been a while since I have discussed, at least I guess 3 or 4 weeks. So I was looking forward to this opportunity, and since no one else is volunteering, I can always jump in. And still I will encourage the new learners to jump in, and if they are ready to, then I can always step back. There are no worries there. So let's see how it goes.
Fantastic, Kirtan. Thank you so much for volunteering to discuss and really being showing us your growth over a year here in Virtual Morning Report. I'd ask you, Kirtan, while we wait for somebody else, can you tell us any some of the highest yield things that you've learned in VMR this past week? What has stuck in your mind in terms of new knowledge that you've had while you've been here?
Yeah, sure. So like talking about the yesterday's case, whenever we come across progressive ulcers, straight away our mind goes to some infectious causes, right? I mean, what if it is some cool endemic mycosis? What if this is non-tuberculous mycobacteria? But the fact that the patient also has suffered from significant weight loss, we have to consider the autoimmune pathologies, right? And then Rafa beautifully taught us yesterday in the teaching points that it's not only about the classic autoimmune diseases like lupus or dermatomyositis or systemic sclerosis, but we also have to consider the autoinflammatory syndromes. So those syndromes which have a role of innate immune system. So classically, we think about Behçet's disease, we talk about relapsing polychondritis, and then we talk about things like Sweet syndrome, pyoderma gangrenosum, because at the histopathologic level, both pyoderma gangrenosum and Sweet syndrome are kind of similar. In fact, Rafa taught us in the last aliquot that it was similar to pyoderma gangrenosum, which suggests that both of them have to some extent, the infiltration of neutrophils in the dermis and the epidermis. So it was very nice to learn about those things, that how we have to consider the autoinflammatory syndromes in certain conditions. And I loved it. So thanks, Rafa, for teaching us.
I love that. I think that's an absolute beautiful reflection. I see Charmaine is texting in the chat to encourage somebody to jump on in or present a case. And I'll say that you know, whenever we see in skin, whenever yesterday as we saw an ulceration in the skin, the temptation is to apply the base rate, which is that, as Zavin mentioned yesterday, a vascular disease, be it arterial insufficiency or venous insufficiencies on the hook. And that's true in the vast majority of cases. If you step back and ask yourself, well, what causes an ulceration in the skin in the first place, without regard to the base rate, you'll see that the same differential diagnosis for a skin ulceration is the same differential diagnosis for a cavitary lung lesion. And we practice the cavitary lung lesion approach much more often in internal medicine than we do with skin ulcer. But a skin ulcer is just basically the same pathophysiology as a lung cavity, except it's happening in the skin. And that's when you realize that there are some other esoteric infections that can cause skin ulcerations, as you mentioned. My personal favorite is leishmaniasis, because Rafa almost stumped us a while ago. But we, I think, emerged right before the finish line. And then, yes, there are autoimmune diseases, there are vascular diseases, there are even medications that can cause skin ulcers, just like cavitary lung lesions. So if you're really thinking systematically about it, you'll ultimately realize whatever causes a lung cavity can cause a skin ulcer and vice versa. And ultimately, it's necrosis of whatever organ, either lung or skin. I see we are yet to have a case. I don't know if Travis or the team has any backup cases in their back pocket today.
We do, Rabbi.
Okay.
Count me in as a last resource.
Alrighty, it looks like the VMR crew is representing today. Sukriti is going to discuss, and then maybe we can use one of our backup pieces to jump on in. So I'll pass the mic to Charmaine to introduce the one and only Sukriti.
Sukriti, she needs no introduction. She is one of the most awesome human beings you'll ever meet. Hi, Sukriti.
Hi, everyone.
Brilliant.
Thank you, Charmaine. I'm Sukriti. I'm tuning in from India today. and looking forward to discussing the case.
It's gonna be great. All right, team. Should we take over the screen with the board? And Rafa, whenever you're ready, thanks again for presenting.
Yeah, I will start when someone starts sharing. I think it's Gerling, right? So this is a 55-year-old man with progressive abdominal pain and weight loss. And that's the end of the other quote.
The one and only Sukriti. Do you want to tag team? Go ahead, my friend.
So we have a 65-year-old male with progressive abdominal pain and weight loss. So the weight loss I translate to, although it's very early in the case and we don't have other signals of inflammation like fever or any other associated symptoms, one way to think about the weight loss is translating it into inflammation. The other way to think about it is to think about whether there's a problem with intake of calories or whether there's excessive breakdown. And in this case, we'd really think about those two other possibilities, and I'd guard against jumping into translating this as inflammation, because we can localize this case to the GI tract. So thinking about the progressive abdominal pain in a 65-year-old, I'd want to know what are his comorbidities, because I think some of the don't misdiagnosis in an elderly patient is an acute mesenteric ischemia. But we don't seem to have like a quadrant localization where I could take possibly an anatomic approach to this abdominal pain. But it's concerning that it's been progressive. I want to know what the time course is to differentiate whether this is just a benign problem versus something that's more concerning. Base rate being queen, probably think of more benign causes at first, but this is VMR, so VMR bias comes into play.
I love it. VMR bias. Should we introduce that as a new cognitive bias into the world? Absolutely brilliant, my friend. I love how you started the case. You went with the harder one of being the weight loss, because it's so broad, and then localizing it to perhaps these two, the overlap of abdominal pain, the Venn diagram of abdominal pain and the weight loss, and thinking more in that realm. And I love, love, love the fact that you thought about mesenteric ischemia, because that's one thing that I was also considering in someone who is more on the older side, with the prevalence of ischemia as a pathology, thinking about like, hey, is this we're dealing with like a chronic mesenteria or acute on chronic mesenteria, which one of us are no misdiagnosis. And while like the weight loss is going to be something that we need to explain whether by acute pathology for any other reason, if it's an unintentional weight loss, just to think about abdominal pain. And the one that I would mention is just our no misdiagnosis, right? If you're hanging with Travis down in an emergency room and thinking like acute somebody coming with abdominal pain, what is our no misdiagnosis? A lot of like the vascular pathology that we considered, from aortic pathology to mesenteric ischemia, thinking about perforations, obstructions, if this patient had a prior history of abdominal surgery of some sort, and then your itises, right? So your cholecystitis, your appendicitis, like those that might need like antibiotics or treatment. So this kind of fits nicely in a mnemonic WIPO. So V for vascular, I for itises, P for perforation, and O for obstructions. And if there's a younger woman, which is not this patient coming in thinking about potential complications. While that is the belly, don't forget, we shouldn't forget about the neighbors of the belly, right? Like if your neighbor, one of my favorite analogy is that like if your neighbor's house is on fire, your house might be getting really, really warm too. So thinking about your ACS, so thinking about getting an ECG to rule out an MI, and also thinking about an older gentleman who I have a pleasure of taking care of them at the VA. Urinary obstructions, pelvic pathologies are the other ones to consider. So I think just making sure to evaluate for those, and then as we get more information to think more about like localizing this abdominal pain, as you mentioned, in the luminal and GI tract is definitely a number one consideration. Rafa, I'll pass it on to you.
Okay, so this is the 55-year-old male that presented with a 2-month history of worsening abdominal pain. This patient also describes significant asthenia and around 17 kilos weight loss in the time frame. 4 days prior to admission, he developed a feverish sensation, but it was unverified. And on the further review of symptoms, this patient describes a poorly localized colic abdominal pain, continuous with lumbar irradiation, and at the moment, the intensity was 8 out of 10. He denies any relationship between the pain and meals or fasting, but he reports hyperexia and recurrent nausea. This patient also describes fluctuating constipation, periods of 5-6 days, but denies blood, pus, or mucus in the stool. He also denies any relevant stool shape changes, and he's urinating as usual. This patient also has intermittent distal numbness of both hands and feet in the last month. And he noticed skin darkening, mainly in the face, for at least 1 month. And now he refers emergency of darkish spots in hands. When it comes to past medical history, this patient has no known comorbidities, allergies, past surgeries, or previous hospitalization. This patient also denies chronic medication use, as well as tobacco and alcohol. He's an infrequent marijuana smoker and denies other drugs. And he was born and raised in an Umber area and works as a taxi driver. And this patient has no antecedents of recent travels or unusual activities. And that's the end of the other quote.
Kirtan, my dear friend, it got really, really spicy now. You told me that Gujarat is the land of the sweet. And I'm worried that we're going to have to accumulate your sweet to combat the spicy here. Before we analyze the case, I'm curious what you're making a list for as your problems. Before we dissect each problem, what would you say are the problems that you've identified that are important to address?
Yes, sure. So the problem that I have identified is that the weight loss, although 17 kg looks like a big number, but the fact that it is so significant, the patient has asthenia, that is concerning to me. From that, the patient initially had numbness only limited to the hands, but now it is also involving the feet. So that is kind of concerning because it suggests that the condition is progressing. So rather than spontaneously improving or somehow stabilizing, the condition is worsening. So that is a point of concern. So Ravi, do you think those are nice points or we should consider further things?
I completely agree. I think our list is abdominal pain, weight loss, skin changes, namely hyperpigmentation, and neurological changes. How do you think the constipation fits in? Can you collapse that into one of the previous problems, or is that a separate problem for you?
Yes, sure. So it definitely seems like something related to the underlying problem, but it might suggest the emergence of new condition or the evolution itself of the underlying condition. And as the Charmaine and Sukriti discussed, that whenever we have abdominal pain along with the weight loss, we have to consider some of the eye testing. So one of the things which I was initially considering, that if the patient was indeed alcoholic, then we can get chronic pancreatitis kind of thing. And then chronic pancreatitis can cause such abdominal pain, such weight loss, and it can even lead to malabsorption, right? So that is something to consider. And given the fact that there is significant weight loss and now there is some constipation, so and even nausea is prominent. So whenever we have nausea, we also have to consider certain endocrinopathies, right? So we have discussed numerous times on VMR previously that how adrenal insufficiency is kind of mimical, right? How it can mimic numerous things, and we should never forget that. And of course, if it is indeed primary adrenal insufficiency, then you can even get skin darkening, right? Because the ACTH levels will go up, and the ACTH will eventually stimulate the melanocyte stimulating hormones, and that can cause the hyperpigmentation. And it is also just like mesenteric ischemia, we shouldn't miss condition because it is very morbid and there is a treatment there, so we should fix that. So that is one thing to consider. Apart from that, now the patient has constipation initially didn't have. So what if the patient had some sort of obstruction in the GI tract which was causing this nausea and this abdominal pain, and now it has progressed to such an extent that it is almost near complete obstruction of the bowel, and that's why the patient has constipation. So things like colorectal cancer, because the patient is above 55 years of age, and we should always consider malignancies which are common like colorectal cancer. So it can present in this way. And of course, then certain hematologic malignancies, we should never forget the lymphoma, because lymphoma can involve the peritoneum, it can involve the bowel wall itself. So it can also present as abdominal pain and all these things. Now, talking about the skin pigmentation and the probably neuropathy, we are not sure about it, but let's say it is neuropathy as of now. Then what if the underlying condition is causing malabsorption? What if the patient has vitamin B12 deficiency, vitamin B1 deficiency, vitamin B3 deficiency, vitamin B6 deficiency, right? So all of those classic vitamin deficiencies can cause neuropathies, and they can cause distal, sensory motor, symmetric, ascending neuropathies. So we are not sure how the pattern is as of now. We will see along the course that how it progresses, but vitamin B12 deficiency is certainly something to consider because it can even cause hyperpigmentation. Classically, it causes hyperpigmentation on the knuckle regions, not on the face regions, but certainly if severe enough, it can contribute to it. And again, if it is indeed a pellagra kind of thing, right, then we can even see the nausea, diarrhea, and now we have constipation. We can put that aside as of now, but it can even cause skin rash like blackening of the skin, right? So that is one thing I am worried about. And apart from that, as for neuropathies, usually we think about diabetes can cause it, some heavy metals can cause it, some autoimmune conditions can cause it. But as of now, we don't have enough evidence from the GI tract that what autoimmune condition can cause this. And the patient doesn't have history of diabetes, as you rightly mentioned that I am coming from the sweet land, so we have to consider diabetes, but the past medical history is not there. But we can surely check the glucose levels, check the HbA1c to make sure that diabetes is not lingering in the background, and it can certainly contribute to this neuropathy. So yeah, those are my things. Probably some vitamin deficiency, probably some malignancy, which is now obstructing it, and the weight loss is very concerning. So now, Rabi, can you guide me how we can approach this further?
Kirtan, your discussion alone is sweet enough to induce diabetes, even in somebody who is at zero risk for it. That was magical. I'll try to summarize what you said. I think you first used the fact that the pain is radiating to the lumbar spine to invoke retroperitoneal disease, and you married retroperitoneal disease with abdominal pain and weight loss and thought of chronic pancreatitis. You then summarized the numbness and tingling to neuropathy and connected them to the GI tract by worrying most about nutritional deficiencies like vitamin deficiency. You also taught us an approach to hyperpigmentation, prioritizing adrenal insufficiency, diabetes, vitamin deficiencies. You also then reflected on how to marry these concepts and use the constipation to invoke malignancy, like lymphoma and colorectal carcinoma, and many other things that I probably missed. The truth is that this problem is too complicated to solve efficiently now, and the most that you're trying to do is to try to collapse it into a simple problem as possible. It's no different than when the good old days of algebra, when you have an equation, and the first task is not to solve the equation. The first task is to eliminate redundancy. And so if you have an equation with an x on one side and an x on another side, your goal is to try to reduce the number of x's and make it as simple with x just on one side, right? And so the question is, how can we simplify this problem? And I think instead of making it, I think you cannot collapse the hyperpigmentation, you cannot collapse the abdominal pain, you cannot collapse the weight loss. But the question is, what can you do about the constipation? And I'd venture to guess that the constipation, which can be one of two things, it can either be an obstructive constipation or a neuromuscular constipation. Those are the only two ways that the GI tract stops working. Either there's something in the way, like a mass, or the neuromuscular apparatus which propels food through the GI tract or poop through the GI tract is no longer working. And here, the long-standing duration of the syndrome, weight loss for a long period of time, might have resulted in a much more sinister bowel issue had the patient had a mass. And I am more and more suspicious, given the persistence of the constipation without progression to fulminant issues like toxic megacolon, etc., that this might represent an autonomic neuropathy rather than a luminal obstruction. And we could be wrong, but if you're trying to make educated guesses, you might say, hey, the constipation is still ongoing and not super severe. The patient still passes a bowel movement every 5 to 6 days, despite losing 17 kilograms. So much weight has been lost, and yet the bowel is not fully obstructed yet. That's unusual. So if I were to try to simplify this, I might say this is abdominal pain, weight loss, and hyperpigmentation, and then a neuropathy that involves the hands, the feet, and maybe the GI tract. And I'm making that assumption not because I'm sure, but because it might simplify the problem. And I think that if you go back down to the original problem where we started, which is abdominal pain and weight loss, abdominal pain and weight loss simply mean either there is an inflammatory cause of abdominal pain, the differential diagnosis of which you narrated so well, cancers like lymphoma, indolent infections, and some autoimmune diseases, or one of two other things. Either the patient has a painful malabsorptive process, like chronic pancreatitis, or has adrenal insufficiency. And I think painful malabsorption is less likely in the context of constipation. Most patients who malabsorb have diarrhea. And adrenal insufficiency is a very important consideration here. So I would say we're probably dealing with an inflammatory cause of abdominal pain, or adrenal insufficiency, or finally, the effects of heavy metals. So here, I think the most important thing to consider beyond inflammatory causes or vitamin deficiencies is to wonder, does this patient have a heavy metal poisoning? Because that, again, will cause abdominal pain, weight loss, and autonomic constipation. But I think what you taught us there is the myriads of connections between abdominal pain and neuropathy. And I would say for all of us at this juncture, given how non-specific the case is, the real task is to try to simplify the problem and eliminate any X's. And I wonder if the constipation here is more neuropathic versus obstructive, and if that can help us make progress. But we're purely speculating here and I need a lot more data. So I'll pass the mic back to Rafa to give us more.
Okay, so the physical exam. The heart rate was 78. The respiratory rate was 22. The blood pressure was 115/60. The temperature was 36.7 Fahrenheit. And the oxygen saturation was 97% on room air. Generally speaking, this patient is chronically real appearing, and he's pale, 2 out of 4, alert and fully oriented. Neuro and HEENG exams, no significant findings. When it comes to the lungs, it's normal, and the abdomen, it's plain, with bowel sounds present, tender to hypogastric and flanks palpation, without peritoneal signs. Cardiovascular exam, the rhythm is regular with 3 out of 6 systolic murmur, and best heard at Herb's Point. And skin and axis are shown in the pictures. Let me show you the picture. But it's basically hyperpigmentation. As you guys, can you guys see it? So it's basically hyperpigmentation of the hands and also the feet. That's the end of the aliquot.
This case keeps getting more and more interesting, Security. Kirtan and Robbie, that was absolutely brilliant. My friend, what do you think of the exam layering this on their fabulous discussion?
Um, so I think just looking at the abdominal exam from the aliquot first, because of the discussion we've had, it seems compared to the patient, what the patient is complaining of, the exam seems not as bad. So that's something that I'm going to keep in mind. The vitals seem okay. So maybe one way to think about like stable vitals would be that maybe this isn't a very acute presentation, because even the time course can be nuanced. Like a chronic time course could be chronic, like an acute on chronic versus just a chronic progressive. So this would help clarify the time course as truly being chronic. Um, the second thing that stands out to me is the fact that he is pale. We can think of his pallor in two ways. One is that it fits in with the complaints that we got of him experiencing weight loss and asthenia on examination. The other way to think of this, especially in his, maybe he's a little young for this, but also this could be concerning for a malignant process, like a GI malignancy. But the fact that he has no family history and he doesn't seem to be in the age group, this would make that diagnosis but less likely, but just because of the morbidity attached to it, that's something I want to keep in mind. The systolic murmur at Erb's point. So I don't know what Erb's point is, and how I could fit the systolic murmur into this picture. One thing that we discussed before was localizing this abdominal pain and how I could either be outside the abdomen and be part of a like a systemic inflammatory process. But I'm not really sure what to make of that. And then the hyperpigmentation of the hands and feet. So I think um, if I'm thinking fast, this sort of just reminds me of an adrenal process and adrenal insufficiency. But maybe this hyperpigmentation could also be caused by some drugs that he's on. So I'd also want to go back and take some more history, and also consider other differentials. I know Ravi mentioned like a toxic metal poisoning. So that's something I'd want to look up, what kind of metals, whether lead that's associated with constipation and hyperpigmentation could be involved. But he seems to be a little old, and then again I'd have to take more history in terms of where he lives and what he's being exposed to, and especially a drug history would be important. um, and then the tenderness to the hypogastric, the tenderness in the hypogastric and the flank region. Again, if we had to layer this on to the colicky nature that he explained in the HPI, again, this would really help us localize this to maybe a luminal process, possibly the intestines. But I don't know how much weight we should put on thinking like that. And then the peritoneal signs are again, uh, they're reassuring that there isn't something very I'm not sure how make do with the peritoneal signs? Maybe you could help me with that, Sharmeen.
Ah, my friend, you're so brilliant. I really, really love the fact that you went through every single piece as systematically as possible and trying to tie it to this patient presentations and make diagnostic progress. And it's hard to do. I'm right there with you. I think, and I agree with you that this seems to be like progressive of a chronic issue that is going on. And, if I want to tie in that systolic murmur, and Irv's point is it's just like left lower sternal border. Basically, I haven't heard that term in a while too. So if you want to tie the systolic murmur with the paleness, like, hey, if this patient is like anemic and they have a flow murmur, that being said, in someone who is presenting with like chronic, like kind of like maybe inflammatory process, I never want to miss an kind of subacute endocarditis of some sort. So I would definitely get an echo in this patient as well, although it doesn't explain or fit for a lot of the pathology we're seeing, but like something to always, in my mind, consider, as it can have multiple different complications and sequela, and maybe we're seeing one of those sequela here. And the other things with murmurs to consider, that if there's any congenital issue that is now, like if it's a bicuspid valve of some sort, again, like not with the localization, it doesn't fit as well. And anything with kind of like integrity of the vessels and the makeup of those, integrity of the valves and the makeup of that, again, doesn't really fit with that. In terms of the normal neuro exam is very interesting to me, especially as we were trying to think about like, hey, this abdominal pain being some sort of autonomic a dysfunction of the nerves, and that then the neuro exam is like completely normal. So thinking about like, hey, this patient was having some, I believe, like numbness and tingling. It's not reflected on the neuro exam. I would say sensation on exam is really challenging to pick up. I feel like if multiple physicians do a sensory exam, we might get different responses. So I'm just open to the possibility that this was just not captured. And I loved your discussion about the hyperpigmentations. I think whether this is some sort of nutritional deficiency, as Curtin and Rob beautifully discussed, or adrenal insufficiency, I think marrying that with the abdominal pain, both are really good things to consider and further evaluate. So I'm very curious to see what the labs show and go from there. Anything else, Sukriti, that you wanted to talk about that I didn't address?
I don't think so.
Yeah, I'm very curious to see what comes next.
Okay, so the white blood count was 2.83. The hemoglobin was 6.8. The MCV was 112. And the platelets were 56,000. The differential of the white blood count, it was lymphocytic predominant, and even had some eosinophils. 2.5% eosinophils and 55% lymphocytes. So the sodium is 133. The potassium is 4.5. The calcium 8.7. The BUN 20. The creatinine 0.98. The AST was 81. The ALT was 37. The ALP was 38. And the GGT was 12. The albumin was 4.3. The total bilirubin was 1.43, being the indirect bilirubin higher with 1.24. The indirect 1.24. Yes, and the INR was 1.11. The PTT was 10, which is normal. And the CRP was 2.7. HIV and VGRL were tested, and both were negative. And a CT abdomen of the abdomen and the pelvis showed no acute findings, no hepatomegaly, no splenomegaly, no enlarged lymph nodes. And just a couple of more additional labs. The LDH was 3,403. The haptoglobin was less than 10. The direct antiglobulin test was negative, and the B12 was 50, which is low. The folate was 26.8, which is normal. And the TSH was 2.85, which is normal. And the T4 was 1.16, which is also normal. And that's the end of the aliquot.
Kirtan, my friend, where are you at?
Yes, so if we tackle each problem step by step, then first let's talk about the fact that patient has MCV of 112. So of course, first we have to think about the common things. So vitamin B12 deficiency, folate deficiency, that can explain the high MCV. But given the fact that patient has low haptoglobin and high LDH and a little bit high AST, we also have to consider what if to some extent hemolysis is going on. And if hemolysis is going on, then we can have reticulocytosis. Now, usually with reticulocytosis, you tend to get high MCV, but not this much high. You can get something like 105 or 1110, but the fact that it is 112, it ensures the fact that we have B12 deficiency along with reticulocytosis, which is contributing to high MCV. And another interesting thing that the Coombs test was negative. So all the classic things like warm autoimmune hemolytic anemia, cold autoimmune hemolytic anemia are out of the box unless the test was tempered in some way, which is unlikely. But the B12 deficiency itself can cause hemolysis. So this is one of those things which I learned in my second and third year of med school, that when you have insufficient or ineffective erythropoiesis, let's say in thalassemia, let's say in sideroblastic anemias, let's say in heavy metal toxicity, then you can get what is known as intramedullary hemolysis. That is, the red blood cells are destroyed before even getting out of the bone marrow. So that can cause the hemolysis. So that explains the low haptoglobin. Apart from that, the patient has pancytopenia, right? So B12 deficiency can explain that, but we also have to be aware of the fact that what if the patient has lymphoma, which has now moved to involve the bone marrow. So we know that DLBCL, Burkitt lymphoma can involve the bone marrow, but those are usually actually fulminant type of malignancies, right? So they would tend to present more acutely than what we are seeing now. But Hodgkin's lymphoma, chronic lymphocytic leukemia, something like mantle cell lymphoma can definitely present in this way in the chronic stages when they are not visible in the blood, but they are visible in the bone marrow. So we have to consider about the bone marrow processes. Even myelodysplastic syndrome can cause pancytopenia along with diluted MCV. Now we can't connect those things to the abdominal pain, but the fact that patient had like chronic lower epigastric kind of abdominal pain, we can consider the fact that there might be some liquid malignancies lingering in the background. Apart from that, we haven't considered the infections until now because it was not evident to us initially. But now if we think about that, certain infections like Mycobacterium tuberculosis, endemic mycosis like histoplasmosis can involve the bone marrow. They can cause the bone marrow fibrosis. They can cause granulomatous infiltration of the bone marrow. And that can end up causing the abdominal pain, pancytopenia, and if you have the GI tract involvement, then you will eventually get the malabsorption and you will get the B12 deficiency. So B12 deficiency is not the end result. It is kind of reflection of what is going in the background. That is one thing to consider. And if it is indeed a malignancy, then even we know that solid malignancies like let's say prostate cancer, colorectal cancer, they can over the time involve various organs, right? They can involve the adrenal glands itself, they can metastasize to bone marrow, and then they can explain the pancytopenia. And the fact that we initially considered the abdominal neuropathy as one of the cause, then you are right. I mean, we can have lead poisoning, and lead poisoning can present in this way, and we are not sure that his job as a taxi driver entails some kind of exposure to lead. Maybe he's doing more than taxi driving, something like that. So lead poisoning is something we can always consider. And the last thing, we have the LDH, which is so high that not hemolysis alone can't explain that. The LDH is high, it means that you have got massive cell necrosis. So probably lymphoma is there, and even HLH can present in this way. And now, Ravi, can you tell us how we can zoom in all these myriad possibilities?
I completely agree with everything that you said. And instead of reinforcing it, I'll push us along even further and then ask you how you would incorporate the murmur in your analysis.
Yes, correct. So as the Sukriti and Charmin discussed that, of course, we have to worry about the chronic endocarditis, but sometimes when you have got hemoglobin, which is so low, then you can get what is known as systolic flow murmur. So that is also something we can consider. And the fact that it was as the left lower sternal border also makes me worry about the mitral valvular problem. So let's see how it goes.
I completely agree with you. I will say that the murmur may be completely diagnostic noise and reflect the presence of the anemia. Um, if you, and I think I am right there with you. This whole case collapses to why is this patient B12 deficient? And I completely agree with your entire differential diagnosis. And I will add one rare diagnosis to entertain as a low hanging fruit, but prompted by the murmur. If the murmur is not explained by flow murmur, the question becomes what causes a murmur and malabsorption? That's where the rare possibility of Whipple's disease, an infection that affects middle-aged men that presents as a malabsorptive abdominal pain, triggering a B12 deficiency potentially, and was one of the most common causes of culture-negative endocarditis beyond Bartonella. So I think the key question is why is this patient B12 deficient? The most common cause in the United States is dietary restriction of B12, followed closely by pernicious anemia and inflammatory bowel disease and celiac disease, and then the world of esoteria like Whipple's disease, tropical sprue, so on and so forth. So if we get to the bottom of why this patient is B12 deficient, I think we'll get to the bottom of the answer. But if you combine endocarditis, which is not true, and malabsorption, the only overlap that I'm familiar with is the possibility of Whipple's disease. I only mention it for the fun of it. It's very rare. But I hope we get to the case. I hope we get to the bottom of why the patient has B12, replete the B12, and see what we're left with. All right, back to you, Rafa.
Okay, so there are two more aliquots. So further investigation was done and an EGG was performed and it showed inactive chronic pain gastritis, glandular atrophy in stomach body, but absent in enteral, and H. pylori was negative. Endomysial antibody was negative, and the gastrin was 614, which is high. And the antiparietal cell antibodies was positive. And there's just one more aliquot that will reveal the diagnosis.
Again, Kurt and Robbie, that was so beautifully said. Sukriti, please, what are your thoughts?
So I think, like Ketan and Ravi said, that the case would really boil down to why this patient is having B12 deficiency. And I think we've got one clue in the form of this antiparietal cell antibody, and the which is positive, and as well as the elevated gastrin levels. So I'm not sure how to tie this together, Charmaine.
Yeah, no, you absolutely nailed it to focus on the antiparietal cell antibody. That to me makes the likelihood of the pernicious anemia more likely, leading to vitamin B12 deficiency and all the sequela manifestations of that. So that seems the most likely to me, because as like Robbie and Curtin beautifully mentioned, we thought about decreased intake, thinking about malabsorption when it comes to B12, and with that, usually, the stomach is the pernicious anemia, and then the duodenal causes like celiac and and like some parasitic inflammation, chronic pancreatitis, and like IBD in the form of Crohn's, and then sometimes like another B12 that I've seen once, B12 deficiency was caused by lipids and like nitric oxide ingestion that can also causes increased clearance of B2. With all those etiologies, I think with this makes pernicious anemia the most likely diagnosis. Kurta and Robbie, any other thoughts before we pass the mic to Rafa?
0, 0, 0.
Well, one more test wasn't asked. Do you guys have any idea which test was? Does anyone want to say something? Which test would you ask?
Yeah, you know, the diagnosis of pernicious anemia is fascinating. Pernicious anemia is one of those diseases where there's actually a dynamic change in the antibody positivity. If you think about the intrinsic factor coming from inside the parietal cell and the parietal cell shielding the intrinsic factor, what happens is patients early on in their disease can have an anti-parietal cell antibody positivity followed by the exposure of intrinsic factor, and then later on in their disease process do they have a positive intrinsic factor antibody. The anti-parietal cell antibodies is sensitive because it's present early in the disease, but is less specific. So I think if all of us are on board the pernicious anemia train, which I think is the appropriate approach, unless the intrinsic factor antibody comes back as negative, because the anti-parietal cell is very sensitive but not specific, and the anti-intrinsic antibody is much more specific, but at the cost of reduced sensitivity. All right, Rafa, back to you.
Actually, they asked for 8 a.m. cortisol, and it was low. So, do you guys have any idea what's happening here?
We'll pass the mic to the team of Charmaine and Sukriti to share their thoughts.
Were you surprised, Charmaine, by this exam?
I think it definitely explains like the hyperpigmentation of it all. And then, you know, when you have one autoimmune condition, you're more likely to have another autoimmune condition, right? So probably, yes. I thought like with B12, you can get some skin changes as well. So I think that's when we were going down the pernicious anemia route. I was like, okay, like maybe it was related to the B12. However, it kind of tells you that like, hey, you can have more. Nobody reads the textbook, so they can have more than one ideology. So any other thoughts, team?
Yes. Yeah, go ahead, Sukriti.
I think this was a learning point for me. I think the law of proportionality is something we talk about in VMR. And initially when we were considering pernicious anemia, I think layering that on to the patient's symptoms, considering he's had so much of weight loss, may be harder. And I think that could have been one of the pitfalls of not considering another diagnosis. So I think that was something that I learned from this.
Absolutely, Sukriti. What a great point. Kirtan, go ahead.
Yes, so actually I was telling that this is a great deja vu. I mean, if like 2 months back, it was on Thursday, you were there, Rabi was there, and I discussed the case with Dhruv, wherein we had the final diagnosis of adrenal insufficiency, and the patient also had diabetes. So during that time, we actually discussed this, that how we have like APS1, APS2, how the endocrine systems kind of cluster together. If you have one, then you can get thyroid problem, you can get parathyroid problem, you can get celiac sprue, thymoma, all the cool things of APS1 and APS2. So it's really, I'm really glad that it is two things, not the one thing. And just very briefly, I wanted to mention about the gastrin thing, that the high gastrin levels can be probably explained by the absence of acid itself, because it's not the primary gastrinoma kind of thing. But since we are not secreting the acid itself, it's because of the reflex feedback that the gastrin levels are going up. So that might be explaining the high gastrin levels.
Beautiful, Kirtan. Beautiful. Rafa, back to you.
Okay, so this
Robbie, did you want
patient,
to say something?
oh,
Sorry, I saw you unmute.
Oh no, I was gonna be like, holy smokes, what a fun party. When you find one autoimmune disease, go looking for another one. When you find one opportunistic infection, go looking for another one. What a wonderful lesson to learn with you all.
so the case's final diagnosis was Addison disease, secondary to autoimmune adrenalitis with pernicious anemia. And polyglandular autoimmune syndrome, particularly type 2, could be a differential diagnosis, but expected additional features were absent. And epidemiology would also be atypical, more often in women and under 40 years old. And after acute management of glucocorticoid and vitamin deficiencies, chronic replacement was initiated with low daily dose prednisone, leading to symptom resolution and normalization of anemia with monthly IM vitamin B12.
Amazing. Are you going to transition to yourself to teaching points? Is that what's going to happen now? So Rafa, please pass the mic to Rafa for teaching points.
Sakriti, Kirtan, you're both so brilliant. So brilliant. I don't think even right now I'm half as good as you two are. So mad respect. Robbie, always a pleasure. Rafa, you are just crushing it, my friend, with teaching point and presenting. It's such a hard thing to do. And I appreciate you so much. Our unsung hero of the past 2 VMR. Take it away.
Okay, so we had a patient with weight loss and abdominal pain. And first, when it comes to weight loss, we have two other emergencies like Charmaine taught us, including perforation like PUD or obstruction like hernia or vascular causes like, for example, mesenteric ischemia. But also if this was a woman, we have to think about also ectopic pregnancy and also inflammation in the site of appendicitis, for example. And then security reminded us to look at any comorbidities that the patient may have. For example, if the patient had atrial fibrillation, we have to consider acute mesenteric ischemia, or if the patient has cardiovascular factors, we could think about chronic ischemia, chronic mesenteric ischemia. This patient, they tend to avoid eating due to the pain after eating, and there is weight loss associated with that. And then Charmaine reminded that we have to think about our neighbors when it comes to the abdomen. So outside of the abdomen, we have to think about ACS, pneumonia, pulmonary embolism. If this was a woman, we have to think about ovarian torsion or cyst or cancer, but also PID, endometriosis, but also we have to think about the kidneys, for example, in the setting of pyelonephritis or stones. And then Rabi taught us about constipation, which can be divided into two buckets, obstruction or neurodysfunction. Obstruction we can see in the setting of neoplasia, volvulus, small bowel obstruction from adhesions or incarcerated hernias. And neurodysfunction, we could think about autonomic neuropathy, for example, due to vitamin deficiency. And then Kirtan reminded us to think about macrocytosis. The MCV is higher than 100, and there are many etiologies, including vitamin B12 and B9 deficiency, copper, liver disease, erotic aciduria, alcoholism, medications like methotrexate, reticulocytosis, and also multiple myeloma. And then we talked about autoimmune gastritis, pernicious anemia. There is this parietal antibody positivity with decreased vitamin B12 absorption because there is loss of intrinsic factor, and the intrinsic factor is required for B12 uptake in the terminal ileum. And then there are some clues to adrenal insufficiency. This patient had hyperpigmentation and abdominal pain. And in the end, we tried to combine both the AI and the pernicious anemia, and we landed with polyglandular autoimmune syndrome. So thank you, everyone. I hope everyone enjoyed this case. The first time I read it, I really loved it, and I hope you guys also did it.
Masterclass of the teaching points. And thank you for presenting the case today. Thank you all for hanging out. It was absolutely brilliant. I hope to see you all tomorrow for Friday VMR with the Prof Res. Bye, everyone.